Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning in to Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. I'm your host, Joel Berg. And thank you to our Pedo Teeth Talk sponsor, Hugh Freedy, for helping us bring you great content. We couldn't do this without them. Visit them at www.hughfreedy.com. That's HU-FRIEDY.com. We're here today with Dr. Jeff Brownstein. Dr. Brownstein is a pediatric dentist and also an anesthesiologist and is the senior partner at West Valley Pediatric Dentistry and Orthodontics, a multi-facility Pedo-Ortho group practice situated in the western suburbs of Phoenix, Arizona, and it provides dental and orthodontic care for infants, toddlers, adolescents, and adults with special health care needs. He is also a partner in Arizona Dental Anesthesia and Nebraska Dental Anesthesia groups providing mobile office-based care for pediatric and adult patients. You can see his entire CV online. I urge you to take a look at it. We're here today to talk to Jeff about the fact that the ADA has recently certified our 10th dental specialty, dental anesthesiology. Thank you, Dr. Brownstein, for being with us today on Pedo Teeth Talk.
Yeah, thanks for having me.
So, Jeff, now that dental anesthesiology is a recognized specialty of dentistry, according to the ADA, what effects might we see in pediatric dentistry?
Well, really, in the past, there have been multiple associations declaring themselves the authority on sedation and anesthesia. And unfortunately, it's really led to an inability for dentistry to establish unified and concise standards of care. And now that the ADA has recognized dental anesthesiology as a specialty, I hope that all practitioners will look to this single entity as the sedation and anesthesia voice for the dental professional, which will in turn help states and communities establish consistent standards of care focused on patient safety and access to cost-effective care.
So would you say that the anesthesiologists who've been practicing well prior to this new specialty would agree that there have been some issues associated with the fact that there isn't a single standard of care?
For sure. Up until this point, oral surgery and dental anesthesia and pediatric dentistry and even periodontics, they've all had their own standards of care and their own way of providing care. And I think that has really weakened dentistry in terms of sedation and anesthesia. Whereas in medicine, the American Society of Anesthesiology is looked to as the authority, and they're the ones that establish the standards across the board for all the medical specialties.
And even we use their ASA classifications, right? That's
exactly.
That's a standard that everybody uses. So is the group already kind of convening to talk about the creation of such standards so that they're apparent to everybody?
Yeah. We have several committees that have been put together, and really we're trying to pull all the information from medicine, from all the dental specialties, to fabricate one unified stance on how we're going to go forward in approaching sedation and anesthesia for dentistry.
Speaking of sedation, we always talk about a continuum of managing patients with, pharmacological management, that is, starting from nitrous oxide in the office to oral conscious sedation and then general anesthesia. And there are options available in some cases. Sometimes there are no choices. But what changes might we see specifically regarding sedation, specifically in pediatric dentistry, as a result of this new specialty?
Sure. Because oral moderate sedation by the pediatric dental provider over the last half century has proven to be incredibly safe and effective, I really don't see much changing with this care in the near future. However, I think eventually non-specialized dentists might be required to undergo more rigorous training in the field of sedation, which would eliminate the practitioner that takes a weekend sedation course. and has limited understanding of the important concepts associated with sedation. I've been a conscious sedation permit examiner for the state of Arizona for about 15 years, and it's widely evident that a majority of the practitioners that lack formal training in sedation really don't understand the physiologic effects of sedation on their patients. They're merely able to regurgitate information and use a cookbook type approach to sedating patients. So, I can also foresee improvements to the educational requirements of auxiliary staff, such as requiring assistants to take formal airway courses or advanced training in the recognition and management of pediatric emergencies, or a PALS course specifically focused on the dental patient. And just like assistants are required to obtain X-ray or coronal polishing or expanded duty permits in many states, they may also one day be required to obtain sedation permits to help assist with this type of specialized care.
I see. Again, in the category of setting standards, it's all about this standardization and to improve the quality of care and with one standard. So what about deeper forms of sedation that some are using or anesthesia in the office? Speaking of that sort of deep sedation where they're really kind of going into general anesthesia, and we always have that conversation. I'm not an anesthesiologist, but I think you know what I mean.
Yeah. Well, at this time, there's really only 400 to 500 dental anesthesiologists in the U.S., so really access to care is extremely limited. However, as dental anesthesia specialty training programs proliferate at dental schools and more residents graduate, access to deeper levels of sedation anesthesia will expand throughout the U.S. And this will in turn give dentists many more options. Should I perform this care in the office using nitrous oxide or moderate sedation? Should I use a mobile anesthesiologist to provide a deeper level of sedation? Or should I do a complex medical case, in a hospital setting? Ultimately, more options means, cost savings and also greater safety for the patient. And there's really no reason that a healthy but anxious 3 to 4 year old, needing 2-3 hours advanced restorative dental care should undergo numerous visits to the dentist. When there's a cost-effective option of providing this in an office-based setting, or even parents should be forced to pay $6,000, $7,000, $8,000 to have this care completed in a surgical center or hospital, when we do have a safe and cost-effective alternative.
So do you see an active attempt to increase the number of trainees in anesthesia programs as a result of the specialty?
Yeah, there's already been one new dental anesthesia program opening in Chicago, less than a year after becoming a recognized specialty. And there's words of multiple programs opening up at different universities. And I foresee in the next 5 to 10 years that a lot of the dental schools will start having dental anesthesia programs.
That's fantastic. And I think, as you mentioned, that we think of anesthesiologist as managing a general anesthesia case, but you personally have exposed me to the concept of intramuscular short-acting agents like ketamine that only an anesthesiologist could perform. So it really broadens the scope of options for care as well, right?
Oh, there's many alternatives to providing various levels of sedation that really are untapped in dentistry right now.
Yeah, that's fantastic. I think that's really exciting, and I think our pediatric dental colleagues will agree that the opportunities are going to improve and grow with this specialty. So if I'm thinking about starting an office-based general anesthesia in my office, maybe you could define what that is for us. It seems obvious, but you could tell us what that means. What do I need to be thinking about in terms of the facility and also staff training? And it's a long question. I'll come back to the specifics.
Yeah. The first thing is you should identify a mobile anesthesia provider in your area and try to interview several if possible to find the one that best suits your needs. Once you've found one individual, that person will likely help you create a surgical suite right in your dental operatory. This really the specifics or the specific criteria for this suite will really depend upon what type of anesthesia this individual will be providing and also your state requirements. They'll likely request some sort of delivery system for medical gases. They may need your office to store equipment or medications. They may need, or they may request that the office provide staff to help recover patients. They may want you to keep a supply of clean blankets or launder head wraps. They may ask you to purchase recovery monitors or AEDs. A lot of it is just really dependent upon the individual anesthesiologist, the requirements in the state. And it's very possible that the mobile anesthesiologist will actually bring most of their equipment with them, and the requirements for you, the practitioner, would be pretty minimal.
I see. So every state, going back to the state level, every state's going to be a little bit different, but I assume and hope, I guess, that with the advent of the specialty, that states would become more aligned around what's required as standards develop, both and also in terms of facility and training and what the expectations are. Do you agree with that that's going to create more standardization across the country?
Absolutely. The American Society of Dental Anesthesiology, one of the focuses that we have now is to establish that standard of care that all the states and all the communities throughout the United States can look to establish what their specific requirements are. And I expect over the next several years after that comes out, most of the states will kind of fall in line with each other. That's
fantastic. So lastly, you mentioned the training of the staff, and earlier you alluded to it related to sedation as well. So what specifically might the anesthesiologist request or suggest, and what is appropriate for staff training? You referred to the recovery part, but what about during the procedure itself?
Yes. So really each staff member should have a solid understanding of what their individual role is. They need to understand that each person plays a critical role in facilitating this care. Most anesthesia teams will provide like a new office orientation seminar to review this information with the staff, discuss medical emergencies, answer questions. These training seminars frequently include simulating possible events that can occur, during the delivery of this care. Those are the type of things that the mobile anesthesiologist would come in and try to implement within the office. And these sort of things are things that we would review on a regular basis, so the staff has a solid understanding of what their roles are for typical care and also in an emergency situation.
It might be something that would aid in staff recruitment, even though there may be challenges. And for the training side, it gives sort of a promotion opportunity also for staff who've achieved a higher level of training. So
Oh, absolutely. Yep.
Yeah, for sure. Something to aspire towards, for those offices that are doing this. That sounds fantastic.
And we find going into offices, the staff loves to kind of take on different roles. It's not the typical day where they're just providing regular care. They kind of get excited to help out the anesthesiologist and
definitely
put the EKG leads on and just help out in a different way.
Yeah, that's fantastic. Now, I wasn't planning to ask you this since you mentioned EKG leads. I gotta just get your opinion since you're my expert here. About the latest in monitoring and whether it's sedation, GA for sure, about capnography. Can you kind of settle the story for us on what capnography is going to mean for us?
Sure. As of, I believe it's been 2 years now, the American Society of Anesthesiology, the medical group that formulates their standards of care, they have required the use of capnography as a standard for moderate sedation. And I expect the same will probably occur in the next couple years with dentistry. And I'm guessing that the American Society of Dental Anesthesiology will probably, point to this in their moderate sedation standards of care as well.
Yeah. I did a couple of ride-alongs with one of my patient's parents in Seattle who's a paramedic. And he said when they're doing CPR, there's nothing better than capnography to monitor ventilation, and they couldn't imagine being without it.
Sure. Once you've used it, you find that without it, you feel like you're missing something.
Yeah. I can't believe we ever practiced without pulse oximetry, but we did.
Exactly.
We waited for the patient to turn blue to act, and I'm grateful we don't do that anymore. So we will now pause for a short word from our sponsor.
Hugh Freedy is the global leader in dental instrument manufacturing, offering pediatric restorative solutions that keep you performing at your best. For more information on Hugh Freedy products, visit www.hughfreedy.com/AAPD crowns.
We are back with Dr. Jeff Brownstein. We're talking about the new specialty of dental anesthesiology and the exciting opportunities ahead of us. So, Jeff, we were talking earlier about, getting, for those thinking about bringing office-based anesthesia into their office. And so you're interviewing a potential anesthesiologist. There are a lot of things, because we don't know anesthesia. That's why we're hiring an anesthesiologist. So what are some of the good questions we need to be asking them before we make a decision?
Yeah, that's an excellent question. I really think that most dentists fail to do their homework when it comes to identifying someone to provide their patients with office-based sedation and anesthesia services. They assume that all anesthesiologists are created the same, or even that an oral surgeon or a medical anesthesiologist or a CRNA brings more experience or technical skills than a dental anesthesiologist. And it's important that dentists do their homework, understand the skill set and background of every anesthesia provider that can come in and provide them care. Most physician anesthesiologists and CRNAs get very little experience working with pediatric patients or with the placement of a nasal endotracheal tube. And the dental anesthesia provider is really the only practitioner that receives medical training with an emphasis on surgeries in and around the oral cavity. They receive 3 full years of education dedicated specifically to sedation anesthesia exclusively for the dental patient. So, it's important to remember, regardless of the credentials, there's always good providers and bad providers. And dentists need to be diligent in researching the backgrounds and training experience and past histories. Ask for office references and make sure your needs coincide with the type of anesthesia the anesthesiologist is providing. And lastly, interview the anesthesiologist. Ask them questions that are pertinent to providing care for your particular population of patients.
Right. That makes perfect sense. And on the other side of things, I've met through you in some instances some really talented trainees that are about to graduate their anesthesia program, and they seem like people that I would be willing to hire. So without the track record and practice, how would you go about making a decision for a younger person, for example?
Yeah, it's tough, but one of the most important things that I see in a solid anesthesiologist is experience.
Right.
Probably one of the most important. For someone who's been practicing anesthesia for about 10 years now, I look back at my early years where I thought I knew how to manage every situation. And it's one of those situations like flying a plane. The more you do it, the more experience you have, the smoother your technique is, the better you are at managing emergencies, the better you are at identifying emergencies. So that's extremely important.
Yeah, and I guess it would make sense then, if there's a group of anesthesiologists together, even though some had less experience versus others, that group as a whole is going to have a collective, update on training and experience, and they're going to communicate and sort of self-assess, and that's going to be a better situation regardless of the years.
Absolutely, for sure.
Yeah, it's same in dental, same in any kind of practice. That's going to be
sure.
A benefit.
Exactly.
So there's something I heard about this National Fire Protection Agency healthcare facility code 99.
Right.
What does that mean, and how does that affect the ability to do office-based sedation anesthesia? So what the heck is that, first of all?
So the National Fire Protection Agency it's a federal agency that's focused on regulating medical gases and vacuum systems in medical and dental facilities. And for the first time in I believe it was 2018, they dedicated a full chapter in their code manual to the dental facility. And what this agency does is it categorizes medical and dental facilities based on the level of sedation they provide. And this category rating determines the level of compliance the facility must conform to. So dental facilities that provide deep sedation or general anesthesia are considered a level 1 category and must meet the same standards, same gas and vacuum standards as a hospital or an ambulatory surgical center. And unfortunately, the costs associated with complying with these regulations makes it very difficult for a typical dental office to justify providing this level of care. And if these policies, if these National Fire Protection Agency policies are fully enforced, this will pretty much all but eliminate access to deep sedation, general anesthesia in an office-based setting, and will likely force all these patients to be treated in a more expensive manner within a hospital or surgical center.
That's not good. I would hope that's a outcry for advocacy on our parts.
It is, and I think these regulations came out in 2018. They really haven't been pushed, and states are forming alliances to try to prevent the typical dental office from having to conform to a lot of these policies that they're setting forth, just because the cost is several $100,000s to a dental office.
That's crazy. And of course, in the hospitals that do comply with these things and other facilities, they can gain facility fees to offset the cost. We don't have a facility fee, and that's the whole idea of not being JCO certified. So basically it says you got to be JCO certified, sort of, but you don't get paid for it.
Yeah, so exactly.
It doesn't make sense. So yeah, I'm glad you mentioned that to me, and I'm glad we discussed it, because I think our members can help in the way of advocacy. Maybe we don't want to talk about it too much if it's sort of like sleeping at the moment, but we also want to be aware.
Right.
We want to be aware of what's brewing out there. So I think I'm going to follow up myself. Thank you for that.
Sure.
So do you see the need, given this specialty and this amazing opportunity for us to have more training for APD members, for example, and for staff available in various venues?
Yeah, I mean, there's a tremendous need for high quality programs in sedation. It seems like pediatric dental residents now are getting fewer experiences using moderate sedation during their training programs. And this is likely due to limitations created by dental schools and hospitals. But I think that ultimately this void will need to be filled through high quality CE during the annual session or standalone courses if we want to continue to provide moderate sedation services. In the future, I expect a lot of collaboration between the American Society of Dental Anesthesiology and the AAPD. In fact, I see the potential of having combined meetings focused specifically on the pharmacologic management of pediatric dental patients.
Great idea. Let's do that. So you mentioned before that an anesthesiologist who gets pediatric anesthesia training gets a fair amount of it compared to a medical anesthesiologist. So what is the difference in terms of pediatric specific training that you would receive in a 3-year residency versus a medical anesthesia training? Yeah,
so each type of anesthesia provider is required to complete a minimal number of pediatric cases during their training. For instance, CRNAs and oral surgeons have a minimum requirement of 40 to 50 pediatric patients, while a medical anesthesiologist is required to see 100 cases, and a dental anesthesiologist is required to see 125 cases. So it's important to note that each of these specialties has a different definition for what a pediatric patient is. Oral surgeons define a child as anyone under 18 years old, while medical anesthesiologists and CRNA call a pediatric patient 12 years old or under, while the dental anesthesiologist uses the age of 7 to define a child. So you can expect that most residents graduating from a dental anesthesia program will not only have experience providing care for more children, but also for much younger children.
Which is what we care about. Which is what we care about in pediatric dentistry. Yeah,
exactly, and really, they're also the only anesthesia provider that requires residents to care for special need cases. So they're the only ones that have requirements in the special needs community. So these experiences really create a practitioner that is ideal for the management of patients within a typical pediatric dental practice.
Yeah, I could see in hearing all this, because I'm learning a lot myself today, that there's a great need to kind of educate us as pediatric dentists about the kind of training and experience and all the things we've talked about today, to kind of push that out there so we really understand the opportunity and the value of working with a trained dentist anesthesiologist.
Sure, yeah.
Yeah, that's great. So I'm going to do that. So my final question is, given the advent of this new specialty, I hear a lot about the growth of surgery centers. So, I mean, what's this going to mean for the growth of surgery centers that do a lot of dental? I mean, they do other things besides dental, obviously, but for the ones who do a lot of dental, what effects is this going to have on that?
Sure. Yeah. I mean, I think in the future, I really expect that there will be a growth in not only surgical centers, but I think dental-specific surgical centers. I hope, however, that office-based care will continue to remain a safe and economic alternative to the surgical center, as the costs associated with regulating and managing a fixed surgical location will always continue to put an economic strain on the patient, which ultimately continues to limit access to care. And really the reason why obtaining care in a hospital or surgical center remains so incredibly high is because of all the tacked on facility fees, like you said.
Right.
Under the current federal law, Medicaid and insurance payments flow differently depending on whether payments go to an outpatient hospital setting or to a private office. And hospitals and surgical centers get paid more, often several times more, because the system lets them add these facility fees. For instance, a $1,500 office-based anesthesia charge for a 2 or 3 hour dental procedure could cost $6,000 to $8,000 in a hospital setting due to the facility fees. And
that's crazy.
These costs, the costs ultimately get passed down to the patient in higher costs or down the road as increased insurance premiums. And there's really no other mode of anesthesia delivery that can compete with the cost of a single anesthesia provider with an assistant providing mobile office-based anesthesia for the pediatric patient.
We've all seen it, and I think the largest portion of patients are healthy enough to get that kind of care. So we're not taking advantage of what the health system is supposed to be doing, is to drive people to the lowest cost environment, especially for those who are healthy, which is most of our patients.
Exactly.
So that's fantastic. Jeff, thank you so much for all the insight today. I know it's going to be really valuable to our members. I really appreciate you being here.
Yeah, I really appreciate you guys having me.
And thank you to our audience for tuning in to Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice, brought to you by the American Academy of Pediatric Dentistry. We'll see you here next time.
The American Academy of Pediatric Dentistry offers continuing education courses on a wide variety of subjects. Do you sedate children in your office? Attend the Safe and Effective Sedation course. Preparing for your board exam? Attend the Qualifying Exam Prep course. Interested in an overview of the advances in pediatric dentistry? Attend Comprehensive Review. There are so many ways to earn CE with AAPD. Visit aapd.org for more information. For 10% off of any course, use discount code TEETHTALK when registering.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.